I will call on people.
Question here.
So two questions. Could you say a little bit how that software is programmed? Do you program it actually on the cell phone, or you have to do it offline on a computer? And then secondly, one of the biggest problems with knowledge explosion is managing that. And the cell phone, there's so few tools so far to manage. You say yourself, you get hundreds of emails from you don't know. Is there going to be an overload factor for such a small device with such a limited amount of software to actually filter all the things that it needs to provide a useful tool?
Sure. Well, I will. The first question had to do with how does the software actually operate, and you're welcome to download it and have a look at it. I'm not sure how interesting it would be to actually poke through it, but you're certainly welcome to at our website. So the way the software works is it recognizes that the people who create these forms, these public health surveys, are public health workers who have access to an office and a desktop or a laptop computer. Typically, they do not have access to the internet, or it's not always on. It's usually not broadband. But they do have access, again, to a laptop or a desktop. And so the design of these forms is done on a big screen with a Java-based application that enables them to create and share and modify these forms. And then the form is exported to whichever mobile device they're going to use, like a Palm Pilot or a Java cell phone. So that's how that works. And I think the important thing about that is recognizing that, and this is something it took us a while to realize, even immersed in this, is that there are different populations of people that we are trying to reach with different capabilities. Right? We have, for example, rural health workers who now miraculously, again, I mean, I don't want to take away from the fact that it is a miracle that they have a connected computer in their pocket. But it's a very limited connected computer. In most cases, limited to basically a text or, of course, a voice interface. But at the provincial level in most developing countries, and certainly at the national level, you are very likely, in fact, to come across people in the ministries of health who have computers that are connected at least with some kind of dial-up, but now more and more with broadband. Very tiny percentage of the population, but they're key people in this kind of a scheme. Right? So for us now, what we're doing is we're working on that project and other projects to say, all right, well, if increasingly the top level people, the program managers, have access to the web, well, then we can use all the great, easy-to-use web development tools to quickly prototype and develop web interfaces to manage this kind of a process. And then we can send it to the people who don't have that kind of stuff and send it to them in a way they can use on the mobile phone. A good example would be continuing education. Now, I can tell you as a doctor, right, I practice in Washington, D.C. In Washington, D.C., like in every state of the union, the doctors are required to do a certain number of hours of continuing education every year, without which you lose your license. So believe me, every doctor gets their CME, right, because they want to continue to practice, because that's their livelihood. And we have lots of ways, of course, even though it's a requirement, it's very easy for us to do that because I can attend lectures at Georgetown, which is the hospital where I'm based for my clinical work. I can go online and look at all kinds of stuff. I have subscriptions to medical journals. I can do continuing medical education on my cell phone, including graphics and charts and everything else. So I have lots of ways I can get CME. Now let's look at an example in the developing world. There's a World Health Organization, a WHO program called IMCI, Integrated Management of Childhood Illness. And it's basically a collection of very simple algorithms taught to folks who have maybe a couple years of college who are working as rural clinicians. These are the people that are providing health care to the huge majority of folks in developing countries. It's not doctors and it's not nurses. It's folks who have lesser training than that, fewer years of training. And those folks, for IMCI, the idea is to teach them really simple algorithms for treatment along the lines of, this gentleman comes in, does he have a fever? Yes. If he has a fever and he's coughing, is he coughing? Yes. If he has a fever and he's coughing, count his respirations, and if they're more than 60 breaths per minute, that equals pneumonia, give him this antibiotic. Right? So it's nothing like the process, or it's very far removed from the process that I might go through in the clinic if you came in. And the idea is basically to make it very, very simple, even knowing that they're going to actually diagnose and treat a lot of pneumonia, more pneumonia than actually is there, because they would rather overtreat than miss pneumonia, because the consequences would be that somebody might die. So IMCI is a great program, but the flaw in IMCI is that people go and they get trained, and then they leave the training, they go out into these rural areas, and they practice for 15 years, during which time they never attend a conference, read a book, see a magazine, access the web, or have any information relating to their practice sent to them in any way. And traditionally, this has been because there's no way to reach these people. It's too expensive to transport them to the capital city. It's too expensive to send them subscriptions to magazines, even if you could find some common address they could go to, because many of them don't have street addresses to send these things to. And so, of course, you can imagine what happens to that person's level of clinical knowledge, their training, over the course of time. It just goes down and down and down. It's exactly the reason we have CME in the United States, because we don't want that to happen here. Well, of course, what has happened in the last 10 years? Suddenly, that person is extremely likely to be walking around with a cell phone. And so we're in the middle of setting up a pilot project now with the government of Cambodia, where the idea will be they're going to be training a group of IMCI workers. So let's say it's 50 people. And half of those people, after the training, they'll all be tested on their knowledge at the end of their 2 weeks or 3 weeks of training to get some idea of, I mean, of course, we're assuming that at the end of 3 weeks of training, their knowledge will be pretty darn high. And then they're going to be sent off. And half of them will receive very simple messages via text message, right, via SMS, maybe once a week. We're still trying to determine the frequency of the messages. We may have 3 groups where one gets no messages, one gets them twice a week, the other one gets it once a week, something like this. So we're figuring out what the entire protocol will be. But the basic idea is, and the basic hypothesis, is that the people who receive messages, which are created from their curriculum, even if they just blow them off, I mean, we're not assuming that people are going to receive a text message that says, treat ammonia with amoxicillin, and they're going to sit there and study it, right? I mean, after a while, people will just kind of glance at it and do it away. But I can tell you that if I had treat ammonia with amoxicillin written on my refrigerator door, I'd never forget it, right? Even if just peripherally I were to see it. So the fact is, we're not expecting to double or double the length of time that they retain all the information. But if we can increase their retention of their clinical information and therefore increase their ability to correctly treat their patients, simply by sending them a few SMS messages a week. I mean, we can work with companies like Vodafone to get even discounts on the already cheap and falling price of SMS messages. Again, you're talking about tremendously inexpensive intervention. I mean, let's suppose we can increase the quality of care provided by 10% for $1 per clinical worker per year. This is miraculous for folks who've been working in public health for the last 20 years. This is amazing stuff. The ability to actually communicate with, in a two-way system, communicate with every person in your universe in the world, every person that you're working with, every colleague, et cetera. And that's, some examples of some of the stuff that we're doing.